It's a very broad topic and need many hours to speak. Very difficult to concise in this short time, especially as a last speaker. So I will try my best to focus it. First of all, as far as overview, we are running this urology clinics, including this infertility patients for a long time. Initially, it was run by dermatology as per ministry laws, then it was completely shifted to urology. And a lot of new cases every month we are seeing. And what we see here, many correctable causes are there, but many are idiopathic causes. And unfortunately, we don't have more facilities of ART supported by government, and many are not affordable to do it in the privates. So as usually before this definition has been described, but little change as our European guidelines, it will be inability of a sexually active non-contraceptive couple to achieve spontaneous pregnancy within 1 year. Generally speaking, 15% of couples do not achieve pregnancy in first year. 1 in 8 couples encounter to achieve first child, and in 50% of these childless couples, a male factor is found. This is according to updated European guidelines. And 30 to 40% of males with impaired semen parameters are idiopathic. This is one of the interesting factors here. You cannot find any reason for the impaired semen parameters. And 20 to 30% couples have unexplained infertility. No male or female causes are found. So as far as reasons are concerned, one common reason here we are seeing is also advanced paternal age. Although most of the patients are young, but with the advanced paternal age, patients are coming, especially those who have married again and want a child is an important issue. As far as these 30 to 40% males with impaired semen parameters without a focusable cause, the most common and most important factor is the environmental pollution. That leads to sperm DNA damage. That is a reason. I will not go in detail of these other parameters like primary or secondary infertility. Everybody knows about it. What is that? So this production of semen is controlled by the hormonal axis in the male. So mostly anterior pituitary is responsible to release the controlling hormones over the testes, and it's governed by the higher center in the hypothalamus. The story starts from the hypothalamus that gets the input from the multiple brain centers, and it is connected via vascular system as well as neuronal system. And in response to higher centers, hypothalamus releases the gonadotropin releasing hormone to the anterior pituitary to release the FSH and LH. And these both hormones act on the testes to do their action. As far as spermatogenesis is concerned, the most important hormone is FSH. LH is not directly involved in the spermatogenesis, but it helps in development. And these both hormones give feedback to the anterior pituitary for control of its secretions. And in between this cycle, many factors can affect this axis. As far as normal physiology of the testis is concerned, it has two segments physiologically as well as anatomically. Both work differently. One is exocrine segment that has seminiferous tubules and that produces the spermatogenesis. Other is endocrine segment, that is interstitial part, contains the Leydig cells that are producing the testosterone. As generally everybody knows, it is a myogenesis process of a spermatogenesis in which primitive totipotential cells in the seminiferous tubules mature to become a spermatozoa. And it takes a long time of 74 days for one cell to become a sperm. And multiple cycles go on concurrently at the same time at that place. Why we diagnose the infertility, especially for the male factor? First of all, to identify the correct and reversible causes of male infertility, to conceive normally or with at least minimal amount of technology. That should be the aim. Second, to identify the irreversible causes that need assisted reproductive techniques, and to know the irreversible conditions in which the man's sperms cannot be obtainable for the ART. That will help to guide them for donation or adoption. And it is also necessary, it will help in this way to find many medical diseases that are associated with infertility, patient may not know from before. And specific genetic causes of infertility that may affect and impact the offspring. That is also one of the reasons we should diagnose the infertility. Now coming to the diagnosis, the history is of top importance. Fertility history, about marriage, about previous pregnancies with all partners, especially duration, previous treatments he got or not, sexual history including erections, timing, frequency, and use of lubricants containing the spermicides or something. Male development history, and any before cancer treatment in the childhood, any specific infections, especially mumps is very important in this, that can cause the testicular damage, and pubertal development. Continuing the history, the medical history of any fevers and systemic illnesses, diabetes, cancer, infections. Infections especially contains this prostatitis, urethritis, any orchitis, any history of genetic diseases like cystic fibrosis and Klinefelter syndrome. Surgical history is very important regarding our urological point of view. Either he underwent any archaeopexy, fixation of testes, undescended testes, any hernia surgery, any trauma to the testes before, or torsion of the testes, any pelvic, bladder, or retroperitoneal surgery for any reason. And especially in elderly, either they have a history of transurethral resection of prostate or not. And one of the most common reasons for the idiopathic male infertility is exposure. And the most common here in Salalah we are seeing is the smoking. And again, the workers, those are working in the factories and some chemical exposure they get, heat they get, those are also need to know. Coming to the physical examination, generally we should see the patient's build. As in female infertility, you know that obesity is the main factor of dysfunction. The same applies to the male also. It leads to the multiple hormonal changes. It leads to the insulin resistance. It leads to the other things. It leads to the hormone resistances and lead to the. So generally we see the build, the ability to calculate the obesity, BMI and all, and virilization we have to check. Hair distribution, genital size, muscle mass, skeletal proportions. Genital examination should be mandatory in each and every case to rule out any anatomical abnormalities, curvatures, phimosis, hypospadias, and testicular examination can give us the idea of testicular size. Okay, and any other masses, there any presence of VAS is there or not, and definitely the palpation of varicocele. That is the most common cause of correctable cause of the varicocele, as we believe. Varicoceles are dilated tortuous veins of the pepinum complexes in the testes, and the rule is they should disappear when patient lies flat. It has a 3 grades, depends on the severity. We should check for the prostatic examination to rule out prostatitis, carcinoma, and general features of hypogonadism we should check. Color blindly, cerebral ataxia, hair lip or cleft palate. Other general examinations contains the liver and thyroid exam. Coming to the lab diagnosis, most of the patients will come to us with the semen report in hand or in the system. Story starts from there. As far as semen is concerned, the minimal requirements to label it as a normal volume should be 1.5 ml. The sperm concentration minimum should be 15 million sperms per ml, and motility 40%, in which the progressive should be 32%. Morphology 4%. And in this semen parameter, one common thing that we are seeing, unfortunately I didn't mention it, is about agglutination, clumps. That is a common finding in presence of infection. What other things we see along these counts is presence of WBCs in the semen. As it's a common sense that everybody can know that it can be due to infection. But there is one confusion here that we are facing. Many times we treat even the patients with pyospermia, even that you see sperm semen contents WBC. So this one confusion that the round cells in the semen that are immature spermatozoa look like same like WBCs in the semen. So in that case, we should use the peroxidase stain to clarify it. Either these are immature spermatozoa or real WBCs are there. And usual causes are mycoplasma, chlamydia, and gonorrhea. Unfortunately, we don't have these specific bacterial cultures for these. Fructose is usually seen in semen, although it is not available in ministry. But it indicates the patency of the tract after the seminal vesicles, because this is produced in the seminal vesicles, and it gives an idea of patency, especially in presence of azoospermia. Now in seminal analysis, the common terms that are used depends on the concentration of sperms. If no sperm, azoospermia. If all the parameters, count, quantity, quality, all are reduced, is called oligoasthenospermia. Or some specific deficiency is there. For example, only motility is reduced, but count is normal. Or motility is normal, only quantity is reduced, that will be a specific parameter. Our next step should be the hormone studies. Now, hormone studies should not be advocated in every case. It should be advocated especially in cases where significant oligospermia is there, less sperm count. And the most important hormone with us is FSH. That is responsible for germinal epithelial development and sperm production. And it is the primary indicator of function of germinal epithelium. In cases where we find FSH is elevated, it definitely indicates the testicular function is lost, means primary testicular failure. And most of the cases are seen with elevated FSH will be azoospermic or severely oligospermic. And most of the cases may be irreversible because testicular epithelial damage is there. Normal FSH levels we usually see in obstructive cases. In those cases, the sperm retrieval is advocated for IUI or IVF, whatever it is possible. Other hormones including prolactin. Prolactin is tested in especially with low testosterone levels. And it is also associated with decreased libido, erectile dysfunction, evidence of hypogonadism. Other hormones that unusually checked, but can be possible, estradiol and thyroid function. Some specialized tests are advocated. On the top will be the anti-sperm antibodies. These are not advocated in every case. And this, here I want to mention one thing. There is a term called blood testis barrier. It is intact in a normal person. And there are reasons in which we are in doubt that this sperm testis blood barrier is broken, especially previous surgeries, in recurrent infections, in reversion of the torsion, in undescended testes, in trauma, and sometimes they say it may be due to varicocele. So with the history of these problems, we should go for the testing of anti-sperm antibodies. It is a complex issue actually. Many doesn't advocate it, and many centers can advocate it. What they do, they decline the function of the sperm, especially the penetration is reduced because these antibodies are bound to the sperm head, and it counts about 20% of unexplained fertility cases. And these antibodies we don't check in the serum usually. We check sperm-bound antibodies. That is the best idea to check about it. Some other tests that are not usually performed and I have never seen done here are cervical sperm mucus interaction, sperm penetration assays, and hypoosmotic swelling. Those tests may be necessary in specialized centers before proceeding with XC. Genetic testing is also important especially with azoospermic cases. And if any clinical doubt of any genetic disorder is there. Most common is Klinefelter syndrome, and most of these cases will be azoospermic. Y chromosome microdeletion, cystic fibrosis, and definitely those cases will not be even getting benefit with ICSI because primary spermatogenic failure. Coming to the diagnosis radiologically, the most common reason for doing an ultrasound is to check the testes for the varicocele, for the masses, any hydrocele, any other unusual findings in the testes. And abdominal ultrasound also is advocated to rule out any reasons in the retroperitoneum that can cause the vas obstruction or any concurrent pathologies there, especially renal agenesis. Now, transurethral ultrasonography, although not common, but can be performed to highlight the presence of the vas and proper evaluation of the seminal vesicles. Vasography, although it is invasive and should not be as a first line and should be done in the specialized centers before the decision of the ICSI, and usually performed by vasotomy, in fact, incision at the stratum between the stratum and culvated tubules of the epididymis. Now, as far as male infertility causes are concerned, we can categorize it in the three types. Pretesticular, those are mostly depends on the hormonal controls from the higher centers, testicular reasons and post-testicular reasons. Mostly the pretesticular reasons are hormonal, and most of them have diffuse abnormalities, and most of them are correctable with the proper specific treatments. Hypothalamic disease, isolated LH deficiency, isolated FSH deficiency, and pituitary disease causing the hypogonadotropic hypogonadism secondary, tumors, infiltrates, and these usually presents with low LH and FSH values. Hyperprolactinemia usually can be due to exogenous causes and pituitary causes also. Coming to the testicular causes, most of them are due to primary spermatogenic failure and caused by genetic disorders. And most of these cases are presenting with azoospermia or severe oligospermia, except this varicocele. Varicocele usually doesn't present with azoospermia. And most of these cases are irreversible. Even these cases, we don't recommend for the ICSI because they don't have any sperms in the testes. Coming to the post-testicular, mostly that is also called obstructive reasons. Obstruction can be at any level, from epididymis, vas deferens, seminal vesicles, and associated ejaculation ducts at the urethra. If we categorize, it will be in congenital blockade, congenital absence of vas deferens, Young syndrome that is associated with chronic sinusitis and other things, and idiopathic epididymal obstruction and ejaculatory duct obstruction, especially in cases of chronic obstruction and all, chronic prostatitis and all. Acquired blockage, somebody has gone under a vasectomy, for groin surgery like hernia, hydrocele, varicocele even surgery can lead to acquired block. And recurrent infections, prostatitis, and even orchitis can lead to acquired block. Functional blocks we often see in the patients with paraplegia and sympathetic nerve injuries, and some pharmacological drugs also impaired the propagation of the sperms into the tract, leading to functional block. Some disorders of sperm function motility are there, and those are called mostly immotile cilia syndromes. And these are caused by the internal defects in the sperms, maturation defects, immunological infertility, and infections also. And mechanical things like disorders of coitus impotence, hypospadias, and timing and frequency will also be included in post-testicular. Now, as far as treatment is concerned, I will mostly focus on our urological management rather than going to the ART. And we should specify these treatment options into two categories. One should be the specific therapies to treat a specific disorder to reverse it. The other will be the empirical therapy to overcome the pathological conditions. Except these things, generally, as in female infertility, you are telling that the obesity, lifestyle changes, quitting smoking, social behaviors, all these things should be addressed. As far as specific therapies are concerned, first of all, we should diagnose the specific disease or reason to treat it. The most common reason is infection. Infection where? Mostly it is in the prostate, in the urethritis, or even at the level of vas deferens. And it leads to usually the poor motility and leading to the poor sperm function. Now, specific staining is concerned to diagnose this thing with leukocyte esterase and concentration of greater cell more than 1 million to diagnose it properly. And what should be the addressed for this thing? Usually antibiotics are preferred and frequent ejaculation and antioxidants are advised to overcome this issue. The other general measure should be taken for coital therapy. Counseling of the patients for proper timing and frequency is important. And to avoid the lubricants as far as possible. And immunological infertility. This is also a complex issue, as I told before, and their diagnosis is also challenging. And a long-term immune suppression with steroids is advisable. If not relieved, then ultimately the next steps will be IUI or IVF. As far as pretesticular reasons that I mentioned before, mostly hormonal, those are treated with specific disorders of that issue and can be reversible. I will not go in details of those. Now, empirical medical therapy, most commonly used for decades, and most of the times getting a good results also. But unfortunately, no proper placebo-controlled trials are available in the literature to address how much percentage these are getting benefit or not. Okay. And this most have been done in diffuse abnormality cases. As in female infertility, we also use clomiphene citrate to accelerate the anterior pituitary to release the gonadotropins that accelerate the spermatogenesis. Antioxidant therapies are commonly used, and these will prevent for formation of reactive species and improve the sperm quality. Vitamin A, C, E, lycopene, omega-3, selenium, zinc, all are used. In empirical use of gonadotropins, this is also used for a long time, but difficult to use clinically because of the pulsatile nature of gonadotropins. It is very difficult to use practically in ideal way to accelerate the, but clinically we are using also and getting a good results. Now, surgical treatments, we are more concerned about it. What should be the aim? Surgery should be attempt to reverse the anatomical abnormality or a pathological defect that helps in normalization of the semen quality. These are the surgeries that we usually do. Varicocelectomy, most common, I will come on that. Sperm retrieval for ART, that should be done in a specific center. Vasovasostomy, I have never seen this before in my life, but is commonly done in Western countries. TURED, that we usually do in ejaculatory duct obstruction. There are some criteria of dilated seminal vesicles to prove there is obstruction in ejaculatory duct. And we should see endoscopically also. Then we finally decided to resect it. Pituitary ablation can be done pharmacologically as well as surgically for the adenomas. Electroejaculation, it is a complex process of ejaculation done in paraplegic patients who cannot ejaculate semen normally. Now the stream retrieval usually done in obstructive azoospermia and should be done in a specific center where the sperm preservation techniques are available. There are multiple techniques, and usually nowadays it is done with the minimal invasive and aspiration techniques. We usually don't do the open biopsy nowadays. This is one picture of the seminiferous tubules containing the multiple levels of sperms. Vasovasostomy, this anatomical recanalization of the vas difference after vasectomy. Is picture-wise, it's easy to understand. At level of vas difference, we usually do vasectomy. At the same level, we have to recanalize it. It is also complex process containing the expertise, and in small instruments and microsurgery expertise are required. TURED, as I explained already, this is the one diagram showing where is the verumontanum and ejaculatory ducts, and this is the endoscopic view. In the picture A, we usually see the dilated verumontanum containing the sperm ejaculatory duct in between. And this is the first loop resection we see, and then second, and in the end you see the all dilated verumontanum containing ejaculatory duct is resected. Now, most debatable topic for the urologist is varicocele. There are a lot of debate. Do not operate the varicocele. Okay, and they are blaming urologists why you are operating most of the times, even asymptomatic males. Lot of studies on that in Cochrane and many other centers. They concluded on one thing: varicocelectomy improves the sperm parameters, count and total progressive motility, reduces sperm DNA damage, oxidative stress, and improves the sperm morphology. But there is no conclusive evidence that a varicocele repair improves the spontaneous pregnancy rate. This is international literature. But here in Salalah, we are operating for a long time. Our seniors must be operating since 20 years before, with the good results, good pregnancy rates we are observing. Unfortunately, we don't have any literature, some report or something we didn't publish, but this is our observation. We are finding very good results after the varicocele surgery. So the one rule, practice rule, only palpable varicocele have been documented to be associated with infertility. Not a normal man with the grade 1 varicocele should proceed with the, and no specific high tests, ancillary procedures should be done. Now, practical guideline in this: do not refer any clinically normal man for an ultrasound to detect a varicocele. Only if it is clinically palpable, then proceed. Role of ultrasound is there to confirm a diagnosis of grade 1 to differentiate from other causes like infections or other reasons, to quantify the degree of reflux, to assess the right side. Right side varicocele has some secondary reasons in the abdomen, like retroperitoneal masses and all. And for example, if patient is not allowing for a clinical examination. Is varicocele surgery effective? If you ask question me, I will say yes, but in selected people, not in all. Many men with varicocele are fertile. If an infertile man, a varicocele may be coincidental. Semen quality will improve in many cases, but not at all. Only some of the benefit terms of pregnancy. Many will achieve pregnancy without surgery on conservative therapy even. So the topic will remain debatable. Do not rush into go to varicose surgery as a first line. First, try to treat conservatively, give time, give at least 6 months conservative therapy, and then consider the varicose surgery. And inguinal varicocelectomy is most commonly performed in Salalah, as I told. And selected cases after failed empirical therapy we do, and especially in cases who cannot afford the ART, symptomatic varicocele, of course, are one of the reasons, and good pregnancy rates are found. This already I explained already. Where we should not do the varicocele surgery, in subclinical varicocele, isolated sperm defect, and normal semen analysis. Which site to be operated, that also on individual patient we have to decide. Mostly in majority of the cases, we have to operate on the left side because of anatomical reasons. But if clinically varicocele is there on the right side and left side it is subclinical, we have to operate both sides. Technique of varicocele surgery, although it is not related to you all, but related to the urology only, most of the times it is done with three techniques: subingual, inguinal, or retroperitoneal approach. Percutaneous embolization also is done. And the goal of all treatments is to stop the retrograde flow of the venous blood flow to the internal spermatic veins to the testes. Okay. The gold standard that we are, although we are not doing here, as far as literature is concerned, is subinguinal, microsurgical varicocelectomy. And other is inguinal, easy, preserve artery, and cremastic vein ligation we have to do in inguinal approach. Percutaneous approach, technically difficult, high failure rates. Retroperitoneal approach is almost obsolete nowadays. Lap or open can be done. And what we are trained to do in varicocele, initially transinguinal, at inguinal level we should operate, use at least loops, artery, and lymphatics, like at all the veins. When experienced, subinguinal approach should be performed with the use of microscope. Thank you very much.